I'm going to run through medications in lupus and a few other aspects of self-care in lupus. So what I thought I'd do is to talk through some of the things that you can do to help yourself, either alongside medication or as alternatives to medication, and then some specific drugs themselves. So I'll talk a bit about painkillers, anti-malarials, steroid treatment, the immunosuppressants and the newer biologic drugs. So that's sort of the outline of what I'll go through. Now I realise that the timing of this afternoon's got a bit awry, so if you look like I'm running too long, you might just wave at me. Okay, so what I would say about treatment in lupus is that lupus is a very variable disease. So one individual will have a very different disease to another individual. So one person may have skin rashes, may have joint pain, another individual may have kidney disease, may have lung inflammation. And treatment of those two people is therefore going to be very different because it's very dependent on the type of disease that they've got and the intensity of the inflammation they've got. And really treatment in lupus and drug treatment in lupus depends on the severity of the lupus or the inflammation of the lupus and what you're trying to achieve with that medication. I'd also say that side effects of drugs vary very much between individuals. So patients are obviously very worried about the side effects, and I'll often have a lot of patients who come who say, I can't take X drugs, say methotrexate, because my aunt took it and it was really terrible, or my cousin's wife took it and it was really awful. So what I would say is that side effects are very variable between individuals as well. Just because you hear one person who has a bad time with one drug doesn't mean that you're going to get those side effects. We don't really have a good handle on why one individual gets side effects and why another person won't. So we're often saying to try these drugs, and once you get side effects we can move on and try something else. We do know that some drugs can cause particular problems, so we're very aware of some of the common side effects of drugs, and this may influence our decision of which drug to use in which person. So we know that some drugs have effects on fertility. Now if you're a 70-year-old woman, that may not be so much of a worry for you as say a 20-year-old newlywed. So that may influence our decision. We also know that some of our drugs may cause weight gain, and that can be a big concern of patients. So really with treatment, there is no one size that fits all. So if you talk amongst yourselves and talk about the medication, I'm sure a lot of you will be taking different things. It may not be clear why you're taking something and someone else is taking something different. And that's really because these factors need to be taken into account. So I'm going to talk about self-care, things that you can do to help yourself, like say either alongside medication or may prevent you needing some medication. So one of the very important things that I try to stress to my patients is the importance of sun protection. So I'm sure that we're all aware that ultraviolet light can activate lupus. So during this summer, we've had a very hot, very sunny summer. I have seen lots of patients come to clinic with lots of skin problems and lots of rashes because we've had lots of UV exposure during this summer. What I say to patients is you should be using high-factor sunblock, and you should use that year-round. So we think in the winter we don't need it, but you still need sunblock. You get ultraviolet light not just from the sun, but also from fluorescent tubing and from low-energy bulbs. So if you are sensitive to it, you should be using high-factor sunblock all year round. Obviously, you need to put it on more frequently, more consistently throughout the summer, but you should also put some on in the winter. You should look for sunblock that has both a UVA and a UVB block in it. Now, I don't know if you know the difference for this, but there are different types of wavelength of light. The UVA is the number rating. So if you have an SPF 15, SPF 30, that's telling you how much UVA you're blocking. It might be UVB actually, sorry. And then if you turn it over on the back, you often have a star rating. That's the UVA, sorry, the number is the UVB. The star rating is the UVA, and that usually comes in as stars up to 5 stars. And you should look for a UVA block of between 4 and 5 stars. So I don't think that's so commonly known. Some of the sunblocks that you can buy have very poor star ratings on the back. I think P20 is one of those that doesn't have a very good star rating, so that's probably one to avoid. Now the other thing with using sunblock regularly is that unfortunately some people do become sensitised to the chemicals in sunblock. They have quite a lot of chemicals in them that work as the sunscreen. And if you have sensitive skin, then it's quite common to become sensitised to that and develop an allergy to sunblock. So what I say to patients is try different brands. Sunblock is actually relatively cheap now. You can buy it in supermarkets, in chemists, all over the place. So try different ones. And if you have a particular problem with sunscreens, it's worth looking for some that are mineral based. So these are titanium or zinc oxide based. And they have the sunscreen blocking factors from the titanium or the zinc oxide and not from a chemical sunblock. So that's just something to look out for if you have problems with them. Something else to think about is diet. So I have lots of patients who come to me in clinic say, is there anything I can do with my diet that will help my lupus? So there's no specific thing that you can do with your diet that's going to get rid of your lupus or particularly settle your lupus down. But there are a few things which show some interest. So the Mediterranean diet, which I'm sure many of you heard of, which is a diet that is rich in vegetables, grains, fish, low in saturated fat, low in meat, particularly good if you are eating it on a Mediterranean country sitting by the sea. But if you're in Dudley, still a Mediterranean diet has been shown to have an anti-inflammatory effect, and there's some evidence that it may be helpful in the long term for a number of conditions. There's some evidence for the use of fish oils. It looks like fish oils are best taken if you actually eat the whole fish. The fish itself cannot take capsules, but that can be difficult to get the 2 to 3 portions of fish a week that they recommend. So fish oils may be beneficial for inflammation. This picture down on the left is turmeric, which has had a lot of enthusiasm about it recently for its anti-inflammatory effect. There are no good studies in lupus, but there is some possible evidence for the use of turmeric for inflammatory conditions. Again, it seems to be better if you eat the actual turmeric itself after it's been cooked, as opposed to taking turmeric supplements. The other things in diet that you should be wary of is high cholesterol is very common. Some of our treatments can affect your cholesterol, so a diet low in saturated fat to low in cholesterol can be important. And also a diet to help manage weight gain, again, which can be an issue in lupus. Exercise. So exercise is very important in all rheumatic diseases. So our muscle mass tends to decline as we get older after our teenage. Certain medication again can affect your muscle mass and if you become inactive. So exercising to maintain your muscle mass is important. I wouldn't suggest you try to get the muscle mass of our individuals up there on the right, but maintain the muscle mass that you've got. Exercise also helps with fatigue, and there's a good study showing that exercise actually improves fatigue in the medium to long term. It's important for bone health and maintaining your bone strength, and it's also useful for your cardiovascular health. So with exercise, I try to tell people to find an exercise that you enjoy, something gentle, weight bearing if you can manage it. If you prefer working out in groups with patients, then things like yoga, Pilates, swimming is all very useful, or even just gentle walking is important to undertake. Vitamin supplements. So again, I have lots of patients coming saying, should I take a vitamin supplement? Is a vitamin supplement important for my lupus? I would have said most people, if you're eating a healthy, balanced diet, vitamin supplements are unnecessary. And there's some good studies saying that it's just an expensive way to pass it out in your urine afterwards by taking vitamins. What I would say is that you probably should consider taking vitamin D, although you may have seen in the news yesterday that there's a study suggesting that vitamin D is of no use for your bone health. But I think that's still in its early days. I would say to everyone, consider taking a vitamin D supplement of between 800 to 1,000 units per day, particularly through the winter months. So from the time that the clocks go back to the time that they go forward again, everybody should take a vitamin D supplement. The other thing that's important is to have your vaccinations, so protecting yourself from infection as much as possible. We know that if you have an active infection, it can activate your lupus on top of that because the infection jiggles up your immune system and then your lupus can reactivate. So what we suggest is that everybody with lupus has an annual flu jab, that you have a pneumococcal vaccine once every 10 years, and if you're eligible, you have the shingles vaccine. However, you do need to check before your vaccines, particularly the shingle vaccine, that you can have it. Shingles is a live vaccine. If you're on a significant amount of immunosuppression, you cannot have it. But the other vaccines you should be safe with. The other thing that I suggest doing to patients is that you do avoid taking some antibiotics. Some of these are known to activate lupus, so these are sulfonamides containing antibiotics, Cetrin and trimethoprim. Trimethoprim is a common one that is used for urinary tract infections, so probably want to be avoided. And then also tetracyclines such as minocycline should be avoided. Minocycline was commonly used to treat acne, and it's been shown that it can induce an autoimmune condition and can induce lupus relatively commonly, so again it's something that should be avoided. What I'd say to patients is really you shouldn't really take anything over the counter without discussing at least with the pharmacist whether you should be taking it if you have lupus. And then contraception and HRT. Patients who are of childbearing age and actually those that want to become pregnant, pregnancy is usually successful in lupus, but it does need planning and it does need monitoring. So it's important to have adequate contraception if you don't want to get pregnant, but what we say is to avoid the combined oral contraceptive that contains estrogen, unless you have very, very mild disease, which should be discussed with your doctor. And similarly with HRT, lupus is a hormonally sensitive disease, so HRT is not suitable for the majority of people who've had anything more than mild lupus. So then moving on to the medication that we're using. So I always sort of try to think with patients, what are we trying to actually treat when we're using medication? So are we trying to treat pain? Are we trying to treat active inflammation? So is there rashes, joint inflammation, kidney inflammation? So is our treatment mainly trying to suppress that inflammation? And also patients often end up on a lot of other medication which is not directly treating their lupus, but maybe treating side effects or complications of their lupus, such as they may end up on blood pressure medication because they've got high blood pressure related to kidney disease. They may require a statin to lower cholesterol to reduce their cardiovascular risk. They may end up on bone agents, bisphosphonates to try to improve their bone density if they develop osteoporosis. So not all the medication that you end up on lupus will be directly treating the lupus. It may be working on other effects from the lupus disease or other complications from treatment. So I thought I'd talk quickly about painkillers. So there's a variety of ways that we can use painkillers. One of the commonest ways I like to try and get patients to use is to use topical therapies. So these are the topical non-steroidal gels such as Ivy, Voltarol, very easily available, can often be quite effective for superficial joint pains. Then moving on to medication, we try to say the simplest thing first, so such simple analgesics such as paracetamol. Non-steroidal or anti-inflammatory drugs taken by mouth can be useful if you've got inflammatory joint conditions, but we don't like people to take it for too long. So I say short-term usage, 2 to 4 weeks, try to come off it after that. Long-term use of non-steroidals can cause kidney problems, gut problems, and can have heart side effects. So they're not something that I like people to be on long-term. They are very effective, and so sometimes people do struggle to stop taking them because they are very good at reducing their joint pain. And then moving on from them, there's the opiate-based painkillers. So the weak opiates in cocodamol, moving up to tramadol, moving up to morphine sulfate-related drugs. However, these don't obviously come with a variety of side effects. So again, we try to use the lowest dose for the shortest period of time. And really, if you're using painkillers because you've got joint inflammation, then really your treatment to try and suppress the joint inflammation should be changed to try and get better control. So moving into more specific treatments that we use in lupus. So I thought I'd start with the anti-malarials. So these are hydroxychloroquine, chloroquine, mepacrine. Largely hydroxychloroquine. I don't use much of chloroquine or mepacrine now. These are very useful for skin and joint inflammation. They have minimal side effects, although they're not free like any drug from side effects. There's some good studies in hydroxychloroquine showing that they can reduce flares in disease by up to 50%. They can prevent damage occurring in the long term from the lupus, and they have a positive impact overall on survival. So really in my clinic, I try to get everybody onto hydroxychloroquine unless there's a reason for them not to be on it. Sometimes they need another drug in combination with the hydroxychloroquine, but then I tend to add that on instead of replace the hydroxychloroquine with something else. They have one rare serious side effect that they can cause ocular toxicity, so they can cause a problem with the retina at the back of the eye. This is very rare. I think in the 20 odd years I've been doing rheumatology now, I've only seen one patient who has definitely had toxicity from their hydroxychloroquine. The risks tend to rise after about 5 years, but still remains very small. What we suggest, we tell patients that they should have an annual optician's check for the first 5 years, and then they should have an ophthalmology review yearly after that. And that's just come in the last 12 months or so. So if you come to my clinic and you've been on hydroxychloroquine for 5 years, I'll be now referring you to the ophthalmologist. Corticosteroids, more commonly just known as steroids. So these remain very central drugs in controlling active lupus. So they're very useful in that they can be given topically. So if you have active skin disease, topical steroids are often used for that. They can be given by tablet, and the majority of patients will be taking prednisolone by mouth. They can be given injection in the muscle if you have a flare of your lupus, which doesn't require a longer-term increase in steroids. They can be given a steroid injection, which gives a boost that then decays over 4 to 6 weeks, so it comes out of your system. And then in severe inflammation, they can be given an infusion where they're given much higher doses, so an intravenous drip that you'd have as a day case. Lots of people are very worried about steroids. They've heard lots of bad things about steroids. Yes, they do have lots of side effects, but they are very good drugs at controlling inflammation quickly and dampening down inflammation. We try to keep the dose low, so skin and joint problems we're trying to use between 5 to 10 milligrams. If you have more severe inflammation, particularly if you have things like kidney inflammation, you're likely to be on much higher doses, at least initially. But then the aim is always to try to bring that steroid dose down to the lowest maintenance dose possible. As I said, they do have lots of side effects. These tend to be dose dependent. So the higher the dose that you're on, the more likely you are to have these side effects. A big one that people worry about is weight gain. So steroids tend to stimulate your appetite, and they tend to make you crave sweet carbohydrate type things. So bread, cakes, pastry, chocolate. So I always warn patients about this and say if you can control those cravings, they're unlikely to give you much weight gain. But I do understand that's very difficult. We know that they increase the formation of cataracts, so if you're on high or even moderate doses long term, you have a higher risk of developing cataracts. They contribute to bone thinning, and we will be looking at patients who are on long-term steroids to assess their bone fitness over time by DEXA scans and FRAX analysis to see whether they can need further treatment. And they do increase your risk of diabetes. And we do unfortunately still see patients developing non-insulin dependent diabetes, type 2 diabetes induced by their steroids. So they are very good and very useful drugs, but we do know they have significant side effects. So moving on from them, we move into the immunosuppressant drugs. So these are drugs that we will use to suppress the immune system to try to dampen down the inflammation and prevent damage occurring. There's a number of these that we use. Probably the commonest one that's been used for the longest period of time is something called azathioprine, or Immunosuppressants is its trade name. It's been around for more than 40 years now. There's lots of data for its use in lupus, so we know it's useful in all different forms of lupus, skin disease, kidney disease, some of the arthritis. We will often, I will certainly often add it into people who are struggling to bring their steroid dose down. So if we bring the steroid dose down, every time we bring it down, they get a flare of their disease. We'll often add an immunosuppressant in, and azathioprine is one of those that is commonly added in, because it has steroid-sparing effects as such. So we can dampen down the disease with the azathioprine to allow the steroid dose to come down. Unfortunately, its usage can be limited by its side effects. One of the commonest side effects that patients get is they can feel a bit sick with it, and they can have a bit of tummy upset with it. So that can limit the amount of the drug that they can have. And this is a weight-based drug, so the dose that you're on is dependent upon your body weight. And often we can't get up to the dose that we need because people feel a bit unwell with it. It also has effects on the liver, it can have effects on the bone marrow, so you have to have regular blood tests to monitor it. So you initially start off with weekly, then fortnightly, then monthly blood tests, and you need to continue to have those. So saying that we still use a lot of azathioprine, it is a useful drug, and because it's been around for so long, we're very aware of the complications and the side effects from it. Another drug that we use quite commonly is methotrexate. As a rheumatologist, I use more methotrexate in patients with rheumatoid arthritis because it is extremely good in rheumatoid arthritis, in the joint inflammation. But we also know it is useful in lupus, particularly if arthritis, inflammatory arthritis, is a big problem in lupus. And we know that methotrexate can be helpful in that too. It also has steroid-sparing effects, so again we can add it in to people who are struggling with their steroids. It can be taken by mouth or it can be taken by an injection under the skin. Methotrexate is a very long-acting drug, so you need to take it once a week, and then you take a vitamin tablet 3 days after it. And if one of the common side effects of methotrexate, again, is sickness and stomach upset. And a way of getting around that is to give it by an injection, which is given just under the skin. And we teach patients to give their own injections, so they don't have to come up to the hospital every week to have their injection. Again, it has a number of side effects, liver side effects, bone marrow side effects, rarely lung side effects. Again, have to have regular blood tests to monitor these. So really, when we're moving into the immunosuppressants, we're moving up into another layer of treatment, and these drugs all have more complex side effects and more complex monitoring. Now, one of the drugs that has gained an increasing usage in the last sort of 7, 8, 9 years is something called mycophenolate. So mycophenolate was originally used in transplantation to prevent rejection, but it found that it has very good immunosuppressant and immunomodulatory effects, and it started to be used more and more in lupus. The studies on mycophenolate look very good, so it's very good, it's very effective even in the most serious forms of lupus. So we will use it in patients with kidney disease, we'll use it in patients who have brain involvement, as well as patients who have more milder arthritis and skin-related conditions. We've just had a large audit done throughout the West Midlands, the results which are just coming out. And for patients who are attending, well actually it's done across the whole of the country in units, patients who are attending hospitals with lupus, mycophenolate is more commonly used than azathioprine and methotrexate. So it's actually overtaken the use of those drugs in hospital-based patients. The only thing I would say about mycophenolate, it's not particularly useful in inflammatory arthritis. So it's not so good for the joint inflammation that patients get, but pretty good for the other sides of lupus. Diarrhea can be a troubling side effect of mycophenolate, so we tend to start the dose low and build it up. If people can tolerate that, it does get better over time, and so we often try and keep people on mycophenolate to hopefully get things to settle. Again, it needs blood test and monitoring. It does have a host of side effects related to bone marrow and liver side effects. Now, cyclophosphamide, I put cyclophosphamide in here, but I must say I've not used cyclophosphamide in my lupus patients for the last 4 years. So cyclophosphamide is a very old drug. It's one of the drugs that was used in chemotherapy, cancer-type chemotherapy, and it's been used previously for severe life-threatening disease. So it's given as an intravenous treatment, and it's usually given as what's called pulse therapy. So you'd have one infusion, 2 weeks later another infusion, 2 weeks later another infusion, usually for 6 treatments, 6 intravenous infusions. We don't use it as much now because we have much better treatments, and really mycophenolate has taken over from a lot of cyclophosphamide use. So we used to use cyclophosphamide particularly for severe renal disease, particularly for brain involvement, but mycophenolate has really taken over from that. And that's not because cyclophosphamide is not effective, but we know it has some very serious side effects. So we know it can cause infertility. So it was a problem using cyclophosphamide in young women. It does suppress your immune system, can do that quite significantly, so there's an increased risk of infections. It has quite significant nausea, and there are some longer-term complications related to bladder inflammation and bladder tumours with this treatment. So although we still use cyclophosphamide, it's rarely now. We have got better treatments available. So this is a complex slide. It's getting a bit old now, but this is a slide showing two of the main blood cells, the immune cells, that are important in lupus. So on the left we have what's called a B cell, and on the right we have what's called a T cell. Now these cells have at various times in lupus can become activated, produce chemicals, stimulate other parts of our immune system, and in lupus that can become a central problem within the inflammatory process. Now as there's been more and more understanding about the pathological process behind lupus, that's led to people and drug companies looking at whether they can influence that process and develop treatments that might help at a more cellular level to really get to the sort of nub of where the inflammatory process is occurring. So I often say to people, if you think of like methotrexate, mycophenolate, azathioprine as being like a shotgun on your immune system. So they just go and they just blatter the whole immune system. What these newer drugs are doing are more like a bullet. So instead of just acting on the whole of the immune system, they're going to a specific target, just one point in time to try and turn off that process of inflammation. So there's lots and lots of things on here, but the ones that I thought I'd highlight is the one sort of on the top at the left there called rituximab, and then one that's down here on the bottom left called belimumab. Okay? The others are ones that have been in development. We'll just touch on those again. So rituximab. Rituximab works on the B cell, and it temporarily gets rid of some of those B cells within a patient's circulation. It's had quite a checkered history in the treatment of lupus. So it was it's actually licensed for the use of certain types of lymphoma, certain types of blood cancer. And then it started to be used in some people with lupus, and it started to be used in rheumatoid arthritis. And in rheumatoid arthritis, it's been licensed. It's shown to be useful for treatment for the arthritis in rheumatoid arthritis. There became lots of case reports that rituximab was helpful for lupus patients who had severe disease, so particularly renal disease, it started to be used. However, the drug is very expensive. So the cost has come down, but it was costing about £7,000 to £8,000 to treat a patient with rituximab. So the drug company decided to do some studies in lupus itself to see whether rituximab was effective, and therefore they could get a license and they could start promoting it and could start being used in lupus. And I think they fully expected that those studies would be positive, and obviously we'd start using it. But unfortunately, those studies didn't show that rituximab was more effective than the other treatments that we've been using. Now, there's lots of reasons why those studies might not have been positive as such. Certainly, there was a lot of steroid use in those patients in those studies, which might have masked the effects. And unfortunately, that put a big setback on our use of this drug, because then it wasn't licensed for use in lupus, we couldn't get funding to use it in patients, and that became a big problem for those of us who felt, actually, we do know it works in certain situations. So what's happened from there is that we could still use the drug occasionally on a special dispensation type of arrangement, and then we had to collect data on patients who received rituximab. So if you were going to receive it, you had data collected before you had treatment, then you'd have data as you were being followed up with it to see whether it's effective. And that has really been helpful in showing that, yes, it does work in some patients. Again, it's a little bit difficult to know exactly which patients it's going to be helpful for, but certainly now it can be used in certain patients who have severe disease, particularly renal disease, and again there's ongoing data collection with that. What I would say about rituximab is that it's usually well tolerated, so it's given as an infusion, 2 infusions 2 weeks apart. Most people get on very well with it. You can with long-lasting improvement in active lupus. So I've certainly had one patient who had a very, very severe anemia related to his lupus that we just couldn't get his anemia to resolve. He was breaking down his red blood cells with the inflammation. We tried everything else on our arm. We've given him 2 lots of rituximab. He's been off treatment. But otherwise, so he had a really dramatic response to rituximab. And I've had some other patients who've had bad renal disease treated with rituximab who've done very well. So rituximab is one of these drugs that is around. It is difficult for us to access, but it is available, but tends to be reserved after people have not done well with other drugs. And then belimumab. So belimumab must be 4 years ago or so, it became the first drug to be licensed actually for treatment in lupus for more than 20 years. So actually all the drugs that we use in lupus, they're not specifically licensed for it. We know that they work because of various studies. We know that they work in other conditions and we've adopted them. Whereas belimumab, they specifically set out the company to look whether it was useful in lupus. Their studies showed that it does work and therefore they managed to get a license for it. We know that belimumab tends to work best in skin and joint inflammation. It doesn't seem to be so good in the more severe forms of lupus, but that may be more a lack of data than actually lack of effect. It's given by monthly infusions, often alongside other treatments that you want for lupus. And the problems with belimumab, it is very, very expensive. So belimumab, when I last looked, cost about £16,000 per year per patient for treatment. So again, our use of it is very tightly restricted. We have to get, when I'm in Dudley, I have to get special dispensation to be able to use it. I've only had one patient who's used it in the past who actually did very well with it, and I've just got another patient who's starting it. So it is out there. Again, its use is restricted, but for patients who don't do well with other medication or still have active disease despite other medication, it is an option. And as we saw on that slide that I put up before, there are lots of other drugs that are in development. Now, all of these drugs seem to come out with longer and longer names as we're going on. These are all biologic drugs, so they're all these monoclonal antibodies specifically designed to target certain aspects of the immune system. Certainly, eculizumab and abatacept have produced some data which unfortunately hasn't looked particularly promising, and I'm not sure whether they will be continuing. Sapolilimab, I think, has recently produced some data which I'm hoping will be presented more widely at the next meetings. And eculizumab is quite interesting because it was the most expensive drug in the world at one point. It cost about £250,000 to treat a single patient with eculizumab. I think that cost is gradually coming down, but it needs to go probably quite a long way down before we start seeing it used regularly if it looks to be effective in lupus. So hopefully in that talk I've run through things, sort of self-help measures that you can do to help yourself with lupus. I've been quickly through the analgesics, which are commonly used drugs, steroids, where they're used, why they're used, or possible side effects with them. Then our immunosuppressants, and then our biologics, our new